Welcome to Deep Dive Dialogue. Our topic for today is AI enhanced stroke care. AI enhanced stroke care leverages advanced algorithms for faster diagnosis, personalized treatment, and continuous monitoring. It streamlines imaging analysis, enabling early detection of blockade or bleeding, and predicts patient outcomes to optimize interventions. AI powered tools also assist in rehabilitation by tracking recovery process progress, improving care quality, and reducing treatment delays. We have with us to discuss this crucial topic today Dr. Tamagna Ghosh, Director of Products for Neurocritical Care at Qure.ai. He is a seasoned radiologist and product management expert with extensive experience in AI powered healthcare solutions. Specializing in stroke diagnosis and treatment, he leads cross functional teams to develop innovative platforms that enhance diagnostic accuracy, patient safety, and care efficiency. His clinical expertise in radiology, combined with an MBA from IIM Ahmedabad, enables him to align product innovation with healthcare needs and trends. Passionate about advancing patient outcomes, Dr. Ghosh plays a key role in integrating AI into critical care, bridging the gap between technology and clinical practice in evolving healthcare landscapes. Welcome, Dr. Ghosh.
Thank you. Thank you so much for having me. Yeah.
So, Dr. Ghosh, what are the key features of AI solution for stroke, and how does it facilitate stroke diagnosis and management?
Right. So I'll share a bit of my experience from what we do in our company and the product that we have. So when we talk about stroke, there are two, I would say, major diagnoses, right? There's ischemic stroke and there's hemorrhagic stroke, and we kind of do some form of diagnosis for both, right? So for our product is predominantly focused on non-contrast imaging, non-contrast CT imaging. And the reason for that is I think NCCT is probably the most widely used kind of brain imaging that's there, right? Both in the Western world as well as in resource constrained settings in Southeast Asia or Africa. And that's why that's been our core focus. And what we do is we identify hemorrhages, so intracranial hemorrhage on NCCT. Once we do identify an hemorrhage, we're also able to kind of subtype it. So whether it is intraparenchymal hemorrhage, whether it is subarachnoid hemorrhage, so all the 5 types, we are able to kind of subtype it as well, and then do a volumetry. And volumetry is super essential as well because it's easy to kind of identify bleed on an NCCT once you have seen a few, but it's very difficult, and often radiologists will actually use like a plus B plus C by 2 kind of formula, which is just an average, to find out what the volume of bleed is. And here the AI is able to accurately identify the boundaries of the bleed and stack it together to create the volume, right? So we do volumetry. Apart from that, we are also able to identify infarcts directly. So hypertensity is suggestive of infarcts on NCCT. And again, once we identify that there is a potential infarct in the brain on an NCCT, we don't stop there. So if it's in the middle cerebral artery territory, there's something called the aspect scoring. And the aspect scoring is very essential because most of the guidelines for stroke treatment are actually based on these aspect score cutoffs, right? Whether it is less than 5, whether it is more than 5, and that determines whether thrombolysis should or should not be done and thrombectomy can or cannot be done. And so aspect scoring is also automated by the model, and it's able to generate the aspect score. Which ends up saving a lot of time for the radiologist as well as the neurointerventionist or the physician who's going to be treating the patient. The third thing we also do is a direct volumetry. So we are able to tell you how much of the brain in terms of volume in ml is actually likely to be infarcted. So whether it is 5 ml or 50 ml. So this information, coupled with the fact that we can also localize the infarct in the brain, can actually help you give a good understanding of what the prognosis of the patient is going to be like, and also how critical it is to actually treat the patient, right? So if it's involving the Broca's area or the motor cortex, and it's like a 30 ml or a 50 ml infarct, that's going to be that's not going to be a great outcome for the patient. So this kind of preparation for prognosis and taking steps accordingly, that's possible. Apart from these are our main findings. We also do large vessel occlusion detection, and this is done on contrast CT, so CT angiography of the brain, where we identify blocks in the or complete occlusions in the intracranial portion of the internal carotid artery, as well as the proximal segment, which is the M1 segment, and maybe a bit of proximal M2 of the middle cerebral artery as well. Apart from this, we've also realized that stroke, it's easy to say that we've built an AI for stroke, but when it comes to the actual clinical picture, I mean, most often than not, either you get an unconscious patient to the emergency department, or you get, some form of like not very obvious history, right? Like there are cases where it's just a stroke mimic, which is kind of masquerading as stroke. So we also have a few other findings which support the diagnosis of stroke mimics and not just stroke, and that also helps in kind of triaging patients accordingly and categorizing them, right? So we are also able to identify mass effect and also quantify and identify midline shift, which happens in stroke, but it can also happen. It can be an indirect marker of, say, things like tumors, or any other kind of like mass occupying lesion in the brain, or space occupying lesion in the brain. And similarly, we identify fractures as well, and we are able to identify traumatic bleeds as well, because sometimes it could be a postural hypotension and the patient has collapsed, and it's actually the head injury which ends up leading to the symptoms. So we're able to handle some of those as well. So it really brings together like a comprehensive first line suite, I would say, for emergency head imaging and reporting. Yeah.
So I believe that AI is definitely helping you guys, like radiologists, and helping to make efficient diagnosis in time. So my next question is that how does AI-powered solution differentiate between ischemic and hemorrhagic strokes through imaging analysis?
Right. So I kind of touched upon it, but I'll go
Yeah.
in a bit deeper. Yeah. So I think I mean, AI is basically we call it statistics with great marketing, right? So it basically doesn't understand. I mean, it's not like how a human kind of directly reads like this is bleed and this is not bleed. But what it tries to identify are actually pixels and the values of the pixels and how it's distributed. So if I have to put it very simply, I think our models are able to, when we say identifying hemorrhage or hemorrhagic stroke, what it's actually doing is looking at the CT images and trying to find if there are areas of pixels or patches of pixels which are actually hyperdense, which have a high Hounsfield unit, right? And then the distribution of it. Does it mimic what it has learned as the potential distributions of bleed? And that's how it identifies hemorrhagic stroke. Similarly, on the ischemic stroke side, we are able to identify infarcts, and that's basically identifying dark areas of the brain, which is low HU or low Hounsfield unit areas. And again, it has to be in a distribution which follows roughly a vascular territory. Then we know that this hyperdensity is probably due to an arterial occlusion, right? And both of these descriptions are very important, because that's where our confounders come in, right? Like the challenge to an AI which is trained to detect bleed is actually, will it give false alerts for calcification or any other hypertensity in the brain, right? Which actually can confuse maybe a first year resident in radiology, right? So it has to be better than that. And yeah, so it's about training the algorithm on a lot of data and identifying these patterns, right? Which is how it has learned, yeah, to identify both bleed and infarct. Yeah.
Right. So how does AI-powered analysis improve the efficiency of communication between radiologists and stroke specialists across hub and spoke network, ensuring faster decision making for treatment like thrombolysis?
Right. It's a very loaded question. So, if I have to break it down, there's a component of the hub and spoke model. There's also about how do we increase efficiency of communication, right? Or reporting, and also then the players who are involved. That's the radiologists, the neurologists, and maybe other members of the stroke unit as well. So, we've realized that it's not just about the AI or its accuracy, it's also about how is it that the results are consumed, how is it that the results are actually displayed or communicated, and how do we ensure that different stakeholders within a stroke unit actually communicate each other, because that is what actually translates to a faster treatment. That's the end goal. So. So if I have to explain it, I would say that the efficiency is derived from number one, the AI algorithm does not get tired, doesn't take leaves, right? It's active 24/7, and you can throw any amount of volume of CTs to it. It will not kind of falter there. So that's where I think many of the peripheral hospitals or spoke sites today do not have a 24/7 radiologist on call, and that's where an AI can step in. Or even if there is a radiologist, they may be understaffed or there may be a shortage, and there's a lot of volume that is coming into the emergency department. So what happens is, we'll probably report in a first in first out setting. So whatever patient comes first, we don't know which patient is what, and we'll keep reporting it one by one. And what happens is a critical patient like a stroke patient may end up getting delayed for that report, and reporting usually takes at least an hour and a half, in the best of times, if not more. So an AI can generate that report in under 3 minutes, right?
Oh,
Consistently under 3 minutes. And then comes the second part, right? One is giving that initial diagnosis that, okay, this might be an infarct, this might be an hemorrhage, and XYZ is the volume of bleed, and this is where it's located. But then who needs to know this information to be able to act? It's a neurophysician, or it's a first line physician, or it's a neurointerventionist who's either in some other part within the same hospital, or in a hub and spoke kind of setting is in another hospital itself, right? So with the power of the internet and the ability to actually transfer these this critical information in a secured manner through our app, we're able to immediately ping the treating physician, right? That there is a patient which has come into this hospital, has XYZ findings. This is a patient which may be worth treating. How about you take a look and take a final call? Similarly, at the same time, we ping the radiologist as well, saying that, hey, you know what? This is a patient that seems to be having a critical finding. Why don't you report this, first versus reporting the other patients? And we'll also give a template report, right? So we pre-fill it, and then we ask the radiologist to correct it, in case there's some additions to be made or some modifications to be made. So it's actually simultaneously the AI comes up with a solution, sends it across to two or more different individuals or stakeholders, and gets them to communicate on the same platform. So while a physician is able to take that initial call, transfer the patient, we'll do a thrombolysis or a thrombectomy. In the meantime, the radiologist is able to finalize the report and also get it on the same platform. So that's how the efficiency brings in. It's about an AI engine which is tirelessly working and working accurately, and then being able to communicate all of these findings to all the stakeholders seamlessly on a platform which is powered by the internet. Yep.
yeah, I think you have partially answered my next question, that how it is helping the spoke centers to, communicate with the hub, center in the hub and spoke model. If you want to add any other thing, please
Yeah.
go ahead.
Sorry, it's all kind of linked in
Yeah,
to each other, all of these
yeah,
topics.
yeah,
But yeah, I think it's a very, I mean, after visiting so many spokes, speaking to these doctors or those who
yeah,
run these hospitals, it's a very difficult challenge actually for spokes, particularly in India. And I think this story is definitely replicated across Southeast Asia, and even in places, where we think that there's a lot of resources, which is like, Europe or the Western world. Is that number one, there's always a shortage of staff because you're going to be placed in maybe a tier 2, tier 3 city or in a rural setting. The second one is, even managing such patients when you don't have a lot of resources, both in terms of manpower as well as, devices or whatever that you can invest in, imaging or critical life support equipment, etc. There's only that much that they can invest in. So, working within those challenges and then managing patient expectations. When you bring in a patient, you always want that patient to be absolutely cured once they reach a hospital, and that may not be the case depending on how life-threatening the situation is and how late it has been. So these are the kind of constraints that a stroke hospital plays with. So it's very crucial to be able to understand where they come from and what is their standing and what are the constraints that they are playing with, and be able to adapt the AI to it. So it's easy to make an AI that works for the best of hospitals. It's much more difficult to make an AI that works for most hospitals, right? Regardless of whatever the situation may be. What if they don't have an internet connection? What if they don't have a persistent power supply? They might have power cuts, right? What if they have a very old CT machine? Do we not support it, right? If the quality of imaging is not great. So yeah, these are the kind of things that an AI has to be able to overcome to be valuable in real life. And I think we have been able to do that. And these are the learnings that actually transform something which is from the bench, into the clinical setting. Yep.
yeah. That's correct. So my last question is that since the medical imaging are there, into the diagnosis, so especially the CT and MRI. So what type of imaging does the stroke solution support, and how accurate is it in comparison to the manual diagnosis?
Right. So I'll break it down into two. The first part is
Yeah.
fairly simple. What are the imaging modalities we support? So predominantly, as I said, I mean, as an organization, we have taken a very firm decision that, if you want to democratize stroke care with the power of technology and AI, it has to be something, on a common denominator which spans across the globe, be it like a very rich country or a rich hospital, or a well-staffed or resourced hospital, or, the most rural or remotest of hospitals with very limited resources. So that seems to be, non-contrast CT. So most of our solutions are focused on non-contrast CT. We also have solutions which are focused on CT angiography. That being said, we've realized that MRI is an up and coming alternate pathway for imaging. So yeah, it's in the works that we bring out some solutions with certain partners to be able to support that as well. But predominantly right now, we as an organization we focus on NCCT and CTA. Yeah. The second part of it is focused on right, like what is the accuracy, and that is a very difficult question to answer simply because while the statistical accuracy is very easy to quote and these are numbers, right, and I can quote that in the beginning. So our ICH solution is definitely in the high 90s, right, around 98 for sensitivity, and around 95 to 98 for specificity. Similarly, for our infarcts, it'll be in the early 90s, so around 92, 93% spec. Very easy, but it's much more difficult to actually translate it into a clinical setting. So most of the times what doctors perceive or what clinicians perceive is actually your positive predictive value and negative predictive value, right? How much false positive cases am I getting pinged for, and the AI is wrongly flagging it, and how many correct cases how many true cases is the AI actually missing? So it's the false negatives and the false positives that actually drive the experience in the clinical setting. And yeah, so that's where it gets a little complicated, right? Because PPV and NPV are actually a function of what the prevalence is in a situation, right? Like if you happen to have a lot of stroke patients and I have a high sensitivity algorithm, you're going to have a great experience because most of those patients will end up having stroke. But if this is a low prevalence setting and I still chalk it up with a very high sensitivity, you will get a lot of false positives. So what you have realized is it's not and many of our competitors do that, or many other AI solution providers do that, which is just a plug and play, right? You deploy a software, it's just like installing Microsoft Word or any other software, right? You install it and it works out of the box. We've realized that there is always a gap in the expectation versus the experience if we do that. So what we usually spend is a fair amount of time, say 3 months to 6 months, where we study the results, we get some feedback from the doctors, and then we do something called thresholding, where we actually adjust the sensitivity and of course the specificity to be able to kind of match their expectation. Like, are they happy with the set number of false positives? And there's going to be some false positives, but are they happy with that number? Are they happy with some of the misses that will happen, right? So it's always a trade-off, but that's what we try to do. So that's going to be a function of both what the doctor's expectations are and the prevalence that's amongst the patient footfall that you're getting at the hospital. Yeah.
So your insightful discussion is very important, and I believe that many radiologists will follow this path and adapt AI into their clinical practice. And I believe that collaborative effort between healthcare and technology will continue to drive smarter, safer, and more efficient critical care solutions. Thank you so much, Dr. Tamanna, for joining us today.
Thank you so much for having me.
Thank you. Bye bye.
Thank